And hello and welcome to this week's Maternity and Midwifery Hour. I was just checking out on my notes, actually. It's season 18 and session 9, and welcome indeed. My name's Sue MacDonald and I'm the curator for the Maternity and Midwifery Hours and the Maternity and Midwifery Festivals. And it's my pleasure, and it's an absolute pleasure to be chairing this evening's session because I brought along an old friend. And I'm delighted to welcome Nikki Clark. Hello, Nikki.
Hello.
And we have to put Nikki on the spot and ask her to share a moment of the week with us.
Oh,
Nikki.
oh. Well, considering I've been laid up for nearly 3 weeks with this stinking cold, and a squeaky voice, I think it will be the fact that our garden is having a makeover as we speak. It's been 2 weeks in progress. I think it's going to be another 2 weeks, but it is looking fabulous. So that is really cheering me up.
Fabulous. And that's perfect timing because, of course, I have to say I love the spring and it is the best time to have a beautiful garden, isn't it? And the
Absolutely.
spring is coming. The
Hey.
snowdrops are gone and the daffodils are out and the tulips are peeking through. So it is beautiful. Well, thank you, Nikki. We're going to let you have a little rest. I'll do just a 10-minute thing and then it's all yours. And I just need to say a big welcome to everybody. And those of you who are new to the maternity midwifery hour, I know we have a lot of old friends, old in, the experience that they bring, not old. Um, and we have some new people who have registered this time. Now, I'm very aware that this is the 6th year of the maternity and midwifery hour. And we started in the COVID lockdown of 2020 in March. And we really started to make sure that midwives, student midwives, people within the maternity services could have somewhere they could link up and have that sort of lots of information and kind of connection. And we've carried on. We're not talking so much about COVID now, if at all, except when I tell people about the hour. And we're talking about things that really matter in maternity and midwifery. So that's has become our raison d'etre, if you like. And we work along with the practicing midwife and all four maternity who support us. And also, the other thing I must say is everything we do is recorded. So if you should have a power cut or your computer blows up or something dreadful, don't panic because this is all recorded and you'll get a link to this sometime on Tuesday, tomorrow. You'll also get a podcast at 6 o'clock in the morning if you choose to have that on Friday. And also this will come out again next Thursday, so you can actually replay it if you choose to do so. Also, if you want to check out the Mapflix, that's on the resources list that's on the Facebook Live access. You can actually check out the Mapflix catalogue, which is getting bigger because we add every week, we add a lovely maternity hour to our resources, so you can access all sorts of things. And if this is really good, if you're trying to do your revalidation, if you're doing any study or if you're doing an essay or a piece of work for the maternity unit, really good resources there, very up to date. You can access lots of things. The only problem is once you go in there and start looking and listening to some of our lovely speakers, the time just flows away and you can find 3 hours has gone and you've been listening. You have learned loads, which is a good thing, but it can make time go. So make sure you allocate some time for doing this. And I'm also going to say, because I know that Nikki was poorly, and she was right poorly last week, and was desperately wanting to come to talk to us. And we had our lovely students, which was as good and wonderful. But poor Nikki was still poorly and was worried about her voice. But she's come back and she's very apologetic, which she doesn't need to be, because what I want to say is, there's some horrible stuff going on. Look after yourselves, keep up your vitamins and your minerals, your vitamins C and everything. Don't get too tired, because I think that's what does happen when you're working and people are short staffed because there's sickness around. Everyone gets tired and run down. We need to keep ourselves strong and feisty. Now, haven't got that much on the news. Sunday was International Women's Day, which was a lovely celebration of women's achievements and the role in the world today, which was lovely. It's also this week is Safer Sleep Week, and I was just checking out the Lullaby Trust, and I put the link on the resources there as well. Fantastic resources we can share with women and their families, really to help them care for their babies safely and have the safe sleep with that going. It's also National No Smoking Day. For those of you who are maybe giving up smoking, good luck on that one. But it can be done. In fact, I've got 2 people in my family who've done that in the dim and distant past and given up for years and years and years. So it can be done. So good luck with it. The other thing to report is Donna Ockenden has been appointed to chair the Leeds Maternity and Neonatal Independent Review as well. You may have heard that in the news. So I'm sure there'll be some news along the line there as well as us waiting for Baroness Amos to report late spring. Okay, so I'm speaking really quickly because I know that Nikki has got an enormous amount to talk about of things that are really important to us as midwives and as student midwives at the care we provide for mums and babies. So we're going to be talking about how the rising caesarean section rate across the UK and globally is actually reshaping maternity care and has really significant implications for midwives and midwifery across the board, especially in education and practice. And we're going to look at some of the impacts of these, especially on student learning opportunities and how they learn their skills, but also how we as midwives keep our skills. And before we came on, Nikki and I have already had a little chat about this, and things aren't what they should be now. So we're going to be talking about that. So I'm really so pleased that Nikki has come this evening. You'll know Nikki from her work as a midwife teacher or lecturer. She was lead midwife for education at the University of Hull, and she came along during early COVID to talk about the things that I had to do to look after student midwives and make sure they got their experience at the same time as being safe. So I know she did so much work at that point. She's a midwife, she's a nurse, and she's been in midwifery education since 1990, working in all sorts of different institutions, has also undertaken national and international work, giving lots of information about programme approval and how education works, which is what it really means. And she continues to be actively involved at a strategic level in national developments in midwifery. She's very passionate, and you'll find that out. She's very passionate about midwifery and is totally committed to ensuring quality and excellence in the education of all those who experience it. So welcome, Nikki. Thank you so much for coming this evening. The screen is now yours.
Very much so. And I apologise, I'm still a little bit croaky and I may have to cough occasionally, so please accept my apologies. And I have got lots to talk through today. So I am looking at the consequence of a rising caesarean section rate for midwifery and child health. And I've got a lovely picture of a cliff because I believe we are on a cliff edge. And this is why I really feel I need to speak about my concerns on this. Now, caesarean section originated in Roman and Egyptian society as a last resort to save infants after maternal death. So the rapidly rising number of births via caesarean section in the Western countries and the modern world has garnered attention. It is necessary to save lives, and I am definitely living proof of that. I would definitely not have survived my first birth, neither would my son. And so I tried with labour, but anyway, I had to have an emergency caesarean section, and we lived to tell the tale. However, women are now opting for caesarean section by choice. The number of caesarean sections are now outstripping the number of spontaneous vaginal births, and this is not without consequence to the mother, baby, family, and the midwifery profession as we know it. So there's 4 main areas that I'm going to look at. 1, women electing for caesarean section with caesarean birth with no medical need. The impact on the staffing in maternity, impact on the pre-registration midwifery programmes, and risks to the mother and neonate. If we're looking at why women are choosing caesarean birth, and it is definitely gaining momentum and has done over the last few years. So in December 25, the BBC reported that more babies are being born by caesarean section in England than delivered naturally, without assistance for the first time. It's a direct quote. 45% caesarean section and 44% spontaneous vaginal birth means that caesarean section is now how the majority are birthed in this country. The reasons for choosing caesarean section are documented as personal preference, and this I find heartbreaking, that caesarean section is safer, previous experiences, anxiety or fear, caesarean section being the least worst option, medical reasons, and cultural beliefs and societal norms. If we're looking at midwifery staffing, we now see that more doctors than midwives are the lead professional attending a woman in childbirth. It was documented several years before, looking at national health statistics, that midwives were the lead professional attending a woman in childbirth. This is no longer the case. There's such a debate about normal childbirth. I'm not going to even enter into that one. However, normal, by definition, is how the majority present. So if caesarean sections are now the majority presenting as, that is now the normal. There are medical staffing issues, but I'm not going to discuss those today. Midwifery understaffing is nothing new. We've had this in peaks and troughs over the years, definitely more troughs than peaks. And there are different causes and solutions with this. I am going to look at this in further detail. We are looking at midwives becoming de-skilled and the role eroded, and this is something that we really need to get a grip on. Postnatal care is one area that I need to highlight. Very little postnatal care is now actually undertaken by a midwife. And that is, I find, absolutely awful, to be honest. The midwife is trained and educated to understand and detect issues, to ensure maternal and baby well-being, and for assurance and advice and all of those things that go with that. If you look at continuity care, and as a midwife, if we knew our women, our standards, and I'll talk about rules and standards, because I have been a midwife for some time, we used to have rules and standards, and in it was quite explicit that you attended a woman postnatally for at least twice a day for the first few days, usually interpreted as 3 days, and then daily until day 10, or more often if needed, and then weekly until 28 days, and which transfer to the health visitor took place. And in that time, you really got to know the woman and her family and how she was managing, and you could pick up any causes of concern, and you could sort of answer any queries, and it really was a very good purpose. And it's like the old adage, you don't know what you've lost until it's gone. And I actually mourn for those times. Trust in midwifery care seems to be diminishing, and that is only evident in all the reports, and obviously why people are choosing caesarean section. And this is something that we really need to look at. Why is this happening? Why is the trust in midwifery care going? Conversely, where there are high levels of obstetric and midwifery staffing, and this is in global places as well as the UK, does evidence that there are lower caesarean section rates. So if we're looking at staffing in more detail, we are in a bit of a circle, a bit of a cycle, because high caesarean section rate impacts on staff shortages. Staff shortages impact on caesarean section rates. Birth Rate Plus is a midwifery-specific tool that does calculate the recommended number of midwives, and most maternity units do use this. However, it's quite difficult to be responsive to in a short period of time. And so it actually looks at number of births, it does look at complexities, it looks at the trends, and it looks at sort of the geographical data. Appropriate skill mix, again, is looking at what actually constitutes maternity services. Maternity services midwives tend to be seen as the maternity service. I will say that midwives are a part in the maternity service. They are a component, an extremely important component, but they are a component of the maternity services. And we have seen an employment of nurses in maternity come in of late. And this is not without issues, because you have to be careful that the midwife has a protected role and function. And we have to be careful that nurses don't actually fall unwittingly into a scope of practice that they are unable to perform. Clinical expertise in complex care. Now, we know that women are birthing people, they are more complex with the cases, they have more health issues, they are having their babies later in life. And so therefore, this does take a lot more of skill and time and attention. The Care Quality Commission have reported that they have noticed that there are unregistered staff acting as surgical first assistants with all the maternity, with looking at caesarean sections, and this is actually unique to maternity. This is a worry. The escalation policy and movement of staff when staff shortages are highlighted, but this does affect women's choices. The first thing that tends to occur is a home birth facility, then continuity of care facility, and any other choice that women have wanting to have for their care. Also, if midwives are moved from a place of where they are familiar, they often don't feel as part of the team. They often feel that they are unfamiliar with the area, with the people they're working with the equipment, and this does have consequences. There is a low level completion of staff training, again highlighted by the CQC. Again, if you have staff shortages, you would rather look after a woman than do your online learning, but your online learning is essential, because you can't look after your women properly if you haven't been educated to do so and maintain your skills. However, it is a crisis management, and they are seeing that immediate life support and newborn life support is the lowest that is being completed, against the trust average of or the completion rate they're expecting of 90%. Additionally, for midwifery, again, we have a lot of high dependency care that we need to provide for our women who do present with complex care needs. However, in midwifery, there is currently no national training requirements for midwives to provide high dependency care. This is not unlike nursing, where there are training guidelines. So this is just a quote from the CQC report, which sort of evidences what I've just said. The triage midwife also spent a lot of time out of the room looking for someone to hand over to, but everyone was in theatres. This meant it was just me and my partner left alone in the room for long stretches during the birth. The triage midwife came back into the room for the final stage of the birth, but the labour midwife missed it entirely due to being in theatres with other women. I totally understand that there were other women who needed her more than me, but for me, it felt out of control and unsafe. We know that high demand, pressure and work-related stress does affect health and well-being, which leads to high sickness rates, which then puts additional pressure on those who continue to work, with no breaks, working late or unpaid hours, and you need to look at Leah Hazard's work on this. So midwives want to practice safe midwifery. We don't want to give low standards of care. But however, there is a clearly documented impact of chronic staff shortages. We know, I've talked quite a lot, and I will come back to it a little bit further down, but with what we have with universities and issues in practice, with outcomes-focused standards, that quality assurance and quality control are quite problematic. And we are finding that newly qualified midwives are not all at the same level. And this has been evidenced by the preceptorship packages, which are, for many, is a national document, and it's having to be made more bespoke to individual newly qualified due to some gaps or the different experiences that they've had during their programme. This does lead to high attrition and increased referrals to fitness to practice, which again It causes more stress, more worry, more concern, and more anxiety, which will lead to high sickness or could lead to mistakes being made. Midwives themselves need to be upskilled in line with the proficiencies on which they are to assess student midwives. When the standards were published in 2019, they were very, very different to the standards that we had for programmes prior to this. And within the proficiencies, bearing in mind there's 230 plus, and there's more if we're looking at medicines management and for baby friendly initiative. There are a lot to be assessed, and it builds on year so that you become competent in year 3. Many of these are things that midwives didn't always do, and I'm thinking now of the systematic physical examination of the newborn, which used to be a post-registration programme. Midwives did it as an addition to their as post-registration learning. This is now incorporated into pre-registration learning. Midwives are to assess student midwives undertaking something that they currently may not be able to do. So this causes a bit of a bottleneck, and there are things in place that we are working around this, but this is a problem, and it's actually causing some midwives to feel that they're not where they should be, and this is a problem. Midwives, again, don't see the same preparation to become practice supervisors and practice assessors, which is how we do assess in practice our student midwives. This, again, is a change from our previous standards prior to 2018 of the standards for student supervision assessment. We used to have the standards for learning and assessment in practice, which was a mentorship programme that was NMC regulator approved and monitored. It was fixed, there were standards, it was clear what you had to do, what had to be done for people to become a mentor, whereas the SSSA, as we now affectionately call the one since 2018, 19, that it is the preparation is an outcomes focused standard, which is appropriate preparation, which can be interpreted in a variety of ways and is. So midwife practice and midwife assessors and supervisors are also not receiving the same information. There is limited, if any, funded continuous professional development in the workplace, and this is an oversight. Definitely we need funding for this, because if midwives are to upskill and to remain upskilled and to keep on top of their learning, CPD has to be undertaken. Burnout and stress does affect the culture of the workplace, and that in turn does create some stressful learning and experiences for those who work in it. And morale arguably is at an all-time low. Midwifery is definitely in the spotlight, has been now for a few years, with more and more reports being talked about, more investigations and more reviews. This is extremely high-pressured position to be in. This is, I've talked about this is the scope of practice, just to bring us back to this, because this is what a midwife does, and it's the NMC's scope of practice, the document. You only have to click on the QR code and it will take you to the document itself. So if we're looking at how you become a midwife, and the pre-registration midwifery programmes have had much change over the years. Recruitment and retention is becoming a problem. Applications in June 2024 were at the lowest for more than 6 years. And unfortunately, the fact that newly qualified midwives are due to be qualifying later this year, currently does not appear to be a job prospect for many, is not going to encourage people to apply. Now, bearing in mind it will take 3 years at least for those who are not nurses who are coming in from the school or other occupations, or up to 2 years for those who are nurses. So we can't get midwives very quickly. And if we have a reduction applications, we will have reduction in those qualifying. People will retire, they continue to retire, and people are leaving the service. We know that there's a very high attrition rate from the profession, that we are going to have a big gap. And what is concerning is how are we going to fill that gap? We need our newly qualifieds to be in the pipeline. We need them to be employed because this is forward workforce planning. Successful programme completion is on every student midwife's agenda. It's on every university agenda because we want our students to complete. Otherwise, why would we subject them to a very rigorous programme? However, there are barriers to successful programme completion. And many of that is to do with what's happening in universities with the staffing, what's happening in universities with the funding, and what's happening really in practice. And I'm looking at now the birth rate, because student midwives still require 40 spontaneous vaginal births. And if they are becoming fewer and far between, this is a problem. The NMC are quite clear, it is 40 births. So it is not unusual, and it's going to become more of the norm, I would suspect, that students are going to have their programmes extended to meet this requirement. That will have a knock-on, because if students have their programme extended, then they cannot take up births when there are them, when they should do, which leaves a shortfall. There are also criticisms currently being levied at programmes with the content not focusing sufficiently on complex care and post-operative care. Now, this is in response to the high caesarean section rates and obviously women with complex care needs. However, I must draw you back to what the scope and role of the midwife is. And the programme content is focused on the role of the midwife and the proficiencies that are needed to be achieved by students to become a midwife. So if we're looking at the problem, I'm just looking at the time, so how long I've got. We want students to be competent and confident at the point of registration, but we are finding that newly qualifieds are not the same. There are many variations, and the variations, one is length. And that sounds quite strange, but a programme can be minimum of 3 years and can be actually any length of time after that. But the most I know of is 4 years, and that's one programme at Leicester. I stand corrected if somebody else has had a programme approved at 4 years. So if you have a 4-year programme, which actually when the proficiencies were published, as lead midwives for education, we did fight quite hard for a 4-year programme to be the norm, that to be the minimum, because we realised how much had to go into the programme to meet the proficiencies for students to feel competent and confident to be a midwife. However, the KPMG, the NMC, did commission a consultation, and practice and students did not want a 4-year programme. And I can see why. One is an extra year of cost and is all about the student finance situation in the news as we speak. And also, if all programmes suddenly move to a 4-year programme, there would be a fallow year. And that would be a problem for the profession. And again, the short programme is for ones that are nurses and adult nurses only. And this can be anything from 85 to 2 years. Now, I suppose logically thinking, if a programme is 4 years and a short programme is 2 years, as opposed to 3 years and 85 weeks, you can actually include far more content and far more assessment into a 4-year, 2-year programme than you can at 3 and an 85 week. So how can the product be the same at the end when there is such a variation? We look at the content and it is directly tailored to proficiencies. However, we know on our discussions as lead midwives that it's how you interpret the proficiencies, and they can be open to interpretation. It is how you can look at it, and how it's assessed and how it's marked or assessed in practice. Looking again at the midwives who are undertaking the supervision and assessment. Again, if you've had a robust preparation and you are familiar with the programme, because every programme is slightly different at universities, then you are more likely to assess robustly. However, some, if it's quite a limited exposure, then again, the proficiencies are misinterpreted in practice. Assessment is tailored to outcomes, but again, I'm looking at universities. As I said, every university program is different. Every university is configured differently. They have some have a semesters, some have where they have rolling program all the way along. It's continuous. They have year-long programs, without breaking up for semesters. They have assessment points at different times. They have different assessment tariffs for credit rating. Some universities, if for a 20 credit rating module, would have, for example, a 3,000 word assignment. Some universities may have 1,500 or may have 4,000. It depends on the university regulations. So again, the assessment is as robust as a university's assessment strategy. Now, quality assurance is always difficult when you are looking at an outcomes-focused standard, because the example I will give is that we used to have for programs in our standards that the program was 3 years of 45 weeks per year. Fixed. No change on that. So every single program of a midwifery in the United Kingdom was 3 years, and it was 45 weeks per programmed year. Quite clear. You had to be a midwife teacher, you had to have been in practice for a set number of years, you had to have undertaken a certain examination, higher midwifery, advanced diploma in midwifery, and you had to have undertaken teacher training before you could apply for a teaching post. Again, that is not the case. Quality control is how we measure that quality can be assured. Now, if we look at a quality control measure, and I will use off-duty as a quality control measure, that all students are assigned a practice supervisor and a practice assessor for every day in practice. However, what we find in practice is that because of the staffing difficulties, staff actually don't know who's going to be on shift for that day. So they cannot assign a midwife to a student who they don't know is going to be there. So this is a problem. So you can't look at it in retrospect either. So this is a problem. Many do it admirably. I'm just giving you the worst case scenario. Some places do manage this admirably, and you can check, and you feel very reassured. I can tell you that you know that the students are being supported in practice. We used to have, again in our standards, that midwife teachers worked 20% in practice. Again, it really joined theory and practice together, and you were seen and recognised with how universities are configured, that it is very difficult to find time to go into practice. I've talked about the post-reg education, the CPD. The issues affecting universities are predominantly financed. There's a whole talk on this somewhere, but the majority is about financing universities. Universities are struggling, and Universities UK are quite clear that many universities will go under financially if they either don't join forces or something changes. And this means that programs are being cut, staff are being cut, and predominantly more expensive staff, which are the more experienced, are being made redundant. And this is affecting the staff-student ratio of students to university lecturers on programmes. Again, a standard used to be for midwifery programmes, the SSR was 1 to 10. Now, when the Royal College of Midwives did a survey, it is as far wide as 1 to 38 in some areas. Now, that is vastly different. Vastly different. How can you possibly give the same input and support to students if you are 4 times what the standard used to be? And obviously the issues affecting practice are there clear to see in all the reviews. So the NMC know I do say this, that the outcomes focused standards are problematic. So the known risk substances there in section, we'll go on to know what this is for women. Look at the time. So the risks to the mother are well documented: infection, pain, postpartum hemorrhage, postnatal depression, and a longer recovery period. That's quite generic. It's been around for a long time. However, I will say that there is very little evidence of what the risks to mothers are currently, because it's usually midwives that do not, it is not midwives that undertake postnatal care, and many women do not actually seek postnatal care. And so there is very little follow-up for this to be actually quantified. And a report that I'll come to in a minute does actually highlight that that is the case. Importantly, there are risks to babies being identified, and they are now being clearly evidenced both short and long term, and I think this has been forgotten. So if we're looking at the risk to baby, when you're talking about the physiology of labour and going through the birth canal and going around the curve, that, you know, babies, the chest compressed, and we know that fluids are excreted. So we do have respiratory issues that are a problem. Excuse me. The vaginal birthing process protects against hyaline membrane disease, which is RDS, respiratory distress syndrome, due to its mechanical pressure forcing excessive fluids out of the lungs, and surfactant is produced during labour. It's produced in response to stress, and labour stresses babies. Neonates depend on the vaginal flora and external fecal flora to colonise the GI tract with the good bacteria, followed by the neonates producing stomach acid, thereby preventing other more harmful bacteria to colonise instead. Babies are exposed to good bacteria, which is lactobacillus, bacteroides, bifidobacteria, as they travel through the birth canal, and this is designed solely to boost the neonatal immune system and protect the intestinal tract. The microbiome of babies born via caesarean section, however, is mainly composed of Staphylococcus, Streptococcus, and Clostridium, Klebsiella, and Pseudomonas. So good. Now, idiopathic respiratory distress syndrome was seen in elective caesarean section babies, and the earlier the caesarean section was performed, as in with no labour, the higher the incidence of RDS in full-term neonates. And the meta-analysis also suggested that caesarean section, elective caesarean section, and emergency caesarean section were associated with an increased risk of neonatal RDS. And therefore it's been concluded that infants born by elective caesarean section are at increased risk for respiratory dysfunction due to inadequate lung fluid clearance, surfactant deficiency, and increased pulmonary vascular resistance. We are on a cliff edge. Our life-saving intervention has become the norm. Vaginal birth is becoming bypassed, yet evidence tells us it is the physiologically optimal way to prepare baby for the outside world. There is a tsunami of rapid and unprecedented chronic illness in children. This must be seen as another consequence of the rise in caesarean section birth rate. A study of 7 million live births across 4 countries have concluded that if our findings are confirmed, they could inform efforts to reduce elective caesarean section rates that are not clinically indicated. And another study has said that the maternal vaginal microbiota provides newborns with a greater variety of colonizing microorganisms responsible for boosting and preparing the immune system. Vaginal birth is the ideal birth route, and caesarean sections should only be performed where there are medical indications. And just to know, as I said earlier, that Higgins found that all reviewed studies under their meta-analysis highlighted underreporting of postpartum health problems in mothers following caesarean section rates. So the question I have is, are women making informed decisions on this? So with the caesarean section rate hovering at 50%, this is something that we really need to question. Now, the Office of National Statistics for England do produce statistics, and the question is, as a result of our rise in caesarean section rate. Has maternal morbidity and mortality reduced? The answer is no. It is there in black and white. Has the stillbirth rate reduced? No. Are neonatal morbidity and mortality rates reduced? No. Has infant mortality rate increased? Yes. Has child mortality rate increased? Yes. Do these metrics support the trend? Absolutely not. Are those in both education and practice thriving? Absolutely not. What is happening to the midwifery profession as a result? Because I am very concerned about preserving the role of the midwife to what midwives are best at doing, and that is being educated, knowledgeable caregivers in midwifery. Thank you for listening. And I have 2 pages of references that actually support all of these statements. So thank you very much. I think I'm on time, Sue.
Oh, perfect on time.
Hey.
Perfect on time. Thank you very much, Nikki. It was fantastic. I think this, but a little bit depressing.
I know.
A lot depressing. A lot
I know.
depressing. Because the final slide with the outcomes, I mean, I was, as you were asking the question, I was saying, no, no. And I'm sure our audience were doing the same thing, because the whole point about what we do is, and everything, all the kind of initiatives to reduce maternal morbidity and mortality and perinatal mortality and morbidity, it's all focused, and this is completely throwing everything in the air, isn't it?
Absolutely, it's throwing everything in the air, and we really do need to look at the consequence of choices being offered and made, and to ensure that decision is informed. But yes, if we look at this, all the statistics are there for you in this March update.
And these references, thank you so much, Nikki. This is a really good way of doing this. Is all on the resources list. You just click on them, it'll take you straight through, which is really useful, because I know that if I'm looking up statistics, sometimes I go round a corner and it takes much longer, but this way is a very good way of getting a lot of information quickly, which is fabulous. And now everyone now, if there's any questions you've got for Nikki, now's your chance, because we've got a little bit of time ready for that. I mean, I was thinking, this is clearly, and we were talking about this before we came on air, the things we always talk about, the olden days, and we have to be a bit careful about that in a way, because a lot of things have changed and you put it brilliantly about the complexity of care's changed. But the biggest thing for me is we just seem to have less people to provide the care. And I think when you were talking about postnatal care, that really impacted, because I was thinking, the things that we used to do, and I'm not sure we can ever go back to the visits we used to do twice a day for the first 3 days and then once a day, though I think the women and the families found that really good, because that's when you could do the real proper postnatal care and really find out what was happening with the family and the bonding and all the rest of it. But
some women did find it quite constrictive, though, didn't they?
Well, I suppose you always want what you haven't got, because
I know, that's right.
Women getting really upset. We kept them in hospital, and they'd say, "But I want to go home." And you, and now it's the other way. They're saying, "I wouldn't mind."
Can I stay?
Maybe. Now we're talking about personalized care, and do we really have personalized care, Nikki, in the maternity services in UK?
I think offering choice gives that impression. And I think because if you one-to-one care, we know is the optimal for outcomes. Jane Sandal's work on community and continuity of care demonstrated that to know your midwife and to have continuity of care really improved outcomes. For women to have a midwife at their side improves outcomes. That unfortunately is not the case anymore, and midwives are being pulled from pillar to post to work in, and I do use analogy, and I always say that if you have 3 restaurants and only 1 chef, you're going to have a problem.
Right.
And I see labour ward rooms in that light.
Okay.
A midwife cannot be in 3 rooms at
No.
the same time.
No.
One-to-one care, then that is personalised care. If we're looking at birth plans and looking at options, it is ensuring that we give the full picture. And I am so sad when I see that caesarean section is safer. There's no evidence for that.
No. Well, that's what it's said to be safer, but all the outcomes are saying differently. I mean, it's interesting, isn't it? Because when you were talking about the analogy, my analogy, and I've thought about this quite a bit, when you have things for yourself, like going to the dentist, I like having the same dentist all the way through. And being very nervous, and I have to confess to our audience, I am a terrible, terrible patient. It started with Mr. Pretty. My first dentist got bitten and kicked. Okay, I was only 5, but that's that's part of my story. But for me, having the same person is really important. Yes. Having the same dentist, having the same hairdresser, having the same GP, and that's one of the things. It's things like the GP service can be difficult, and midwifery has been the casualty, and it is very heartbreaking. Those of you who haven't had the benefit of having continuity of care as a midwife, because it's fantastic for women and families. It has to be. It's also fantastic for us as midwives, because once you get the hang of it, and once you work out, it doesn't take over your life, but it does mean you get to know people really well. You don't have to, she doesn't have to tell the whole story every time she comes to clinic or whatever. It's a much better way of caring and providing a high quality care.
They know you and trust you, and that's what we've lost. Is the trust, and that again I find absolutely heartbreaking, because all midwives, I believe, want to do a good job. All midwives want to care for their women to the best of their ability. And this is causing the stress, anxiety, and burnout because they are not able to do that. They're asked to undertake jobs that they're not fully trained to do, or feel that they are prepared to do, or feel that they have been given the correct education to do, learning, and that causes all sorts of problems. And what's happening in postnatal care, I think, is really, really sad, because we aren't picking up the data of how women are coping with the outcomes of rising caesarean section rates. Looking at the fact that people are actually immobilised for some period of time, and looking at family support and how that can pan out, and if they have other children, the fact that not many women are attending postnatal care with personal care clinics gives an indication that there's something not right.
Absolutely. No, we'll return to that. We've got 2 questions come in. Thank you to our audience. And now the first one is Rebecca. Hi, Rebecca, who is saying thank you and very interesting. Yes, it was. You're right, Rebecca.
Thank you.
I just wondered about how the increased request for home births will be managed alongside this inclination or readiness towards caesarean sections, including the impact this will have on community midwives or community midwifery. Well, that's if you have an increased home birth request.
It would be good. I mean, community midwifery is very different to how we know it, because again, community midwife is often where resources are pulled from to support labour ward and other areas in the hospital, which impacts on the provision of community midwifery and of course the home birth service. And again, if you're looking at Leah's work, this is where midwives can only work, they're human at the end of the day. They can only work for so long and remain competent and confident in their decisions if they are working safely. And the long hours is not safe.
No, absolutely.
And that has to be really looked at.
Okay, I've got a Danielle. Danielle and hi Danielle. And Danielle says, how can we stop the cesarean section rate rise? Gosh, that's a fundamental question. Student midwife here, currently on placement, and have seen more cesarean and sections and instrumental deliveries over normal SVD births. Thank you. Thanks, Danielle. That's a really good question. It's the key question. Nikki, have you got the answer?
As I say, I'm very keen to know that women are given informed choice, because I think if the risk to the baby is known, I think some women will actually think about this. And I think that as a profession, and certainly the medical profession, need to consider this as well. And we are looking at, some of the markers have changed as to why they might cause concern earlier. And perhaps we need to re-look at that. We need to look at how we operated before, and how we ensured safety. And yes, have been a midwife for a long time, and I'm still quite sad that the pinard isn't used very much because it's not a machine, it's raw data. You are getting the heartbeat as it is. A machine can go wrong. A machine needs calibrating. There's all sorts of things that can happen. And whereas a pinard is cheap, it doesn't cost anything. And it's a very clear way of listening to the fetal heart while feeling for maternal pulse. If you really want a quick
check. I do have some in the background.
And yes, I mean, it's just, with the auscultation study that's just been done, nobody used a pinard. And I just find that extremely sad. And I think we really sometimes need to go back to basics. And I will reinforce what the role of the midwife is. And it is listening to women. It is supporting women. It is ensuring that they're making the right decisions for them, which ultimately only they can decide. But they can only decide when they have all the information. And I'm not convinced all the information is there. And we also need to look at why we are having so many emergency cesarean sections.
I think that's a really good point. Thank you, Nikki. That's good. So Rachel, hi Rachel, is saying, so women are asking for cesarean sections. Where are they getting the information that cesarean sections are safer?
Again, if you look on social media, if you look at social circles, and the amount of people, if ever I see who are having a baby, and they'll go, oh yeah, I've got my section booked. And it's like, why? Why? And I really have to not say that, because, but it's like, it's what's expected. They're going to have the baby on that day. I know the frustration that has come from inductions and the backlog. And all of that needs to be looked at, of timing of inductions and how to clear beds. But again, this is a vicious cycle, because if you have a woman with cesarean section, then she stays on labour ward longer, and that delays somebody coming up to have an induction, which delays a woman having an induction. So then she's deferred for the next day or the next day, and instead sometimes they come and say, I'm going to have a cesarean section because I know I'm going to have my baby.
Yeah.
And I can feel that frustration. So this is something, it's a fundamental problem. And no obstetricians are looking at this as how can this be managed better.
Yes, I always wonder if it's the women are reading and hearing some of the reports that come out, some of which the data that's being looked at and examined is not as contemporary. Some of it's older. And I wonder if they hear that on the news or in the reports and think, well, oh no, I can't. This is terrible. I wouldn't want that to happen to me. And the cesarean section looks like a fast, we can be sorted. I'll know it's all going to be all right.
But we don't. We don't know. It's not without risk. It is not without risk. And I really wish that when we do have the reviews reported on and the media are reporting on it, that they actually put it in context as to how many births are in that hospital and how many are, and I will not use the word uneventful, but we used to call it uneventful until a lady said to me one day, I find it very eventful, thank you. So I've never used uneventful
It's
ever.
a huge event. It's a marvelous event.
But it means that, it went as nature designed.
Yeah.
And I wish that figure would be offset by what we're hearing, because it's not. We're only hearing of the ones, and we're right to hear them, but I think it does scare people.
Mm.
And for having caesarean as the least worst option, I think that's so sad.
It is sad. It is sad on so many levels. Okay, right. We've got that from Rachel, and then we've got Ashley Durant, who says, "Do you think the increased rate of emergency sections is due to inductions too early?" Good question, Ashley.
I don't think I'm best placed to answer that, to be honest.
Okay.
Of course, you have a view, but I think that's an obstetrician. And I think we really do need to look at the care bundles and things and other markers where they should be. I'm not saying they're not. I'm just saying it should be looked at, because induction rates have gone up. Obviously, timelines have changed over the years, and we need to look at why that is, and has it made a difference? And if we're looking at a trend and the trend is not going the right way, then we need to go back to the drawing board. And just because it's written and it's published doesn't mean to say it's set in stone. We have to look at things. We have to evaluate. Everything needs to be monitored and evaluated. And I don't think that's happening at the moment. We're having recommendations and things are changing, but there seems to be, and again, I apologise if I've not seen it, but I don't believe that there is much monitoring or evaluative discourse about what's the interventions and how successful or not they have been. All we are seeing is the consequences.
No, that's good. I think that's a good answer. That'll do nicely. Thank you, Nikki. And then we've got Danielle. Now, Danielle, this is your second question. Hi then, again, regarding proficiencies, I've found the newer qualified midwives are more aware of what students need to get signed off, and have found a struggle with the older qualified midwives, which has had a massive impact on my learning. How can this be made easier for the students and the midwives teaching us? I think I know Nikki's answer for this.
Well, it's the preparation. It has to be down the preparation. Now, there is something that I will add. When I talk about the issues about the triple SA, when I talk about the differences in programs, if, for example, if we take an example where someone's had the shortest program with the least assessment tariff, and the placement areas are quite limited, and then they work as a midwife in that hospital, and then they have a student, then that midwife assessing and supervising is only as good as the experience in her program, or his or her program. And so, to me, we have a worry, a concern that because newly qualified aren't all at the same level, what we don't want is standards to be dropped. We want standards to be maintained. And again, looking at when we did have different standards, we knew that at a certain period that this would be covered, that would be covered, that's assessed on, and we even at one point had a national exam. So everybody who qualified at that time had sat the same 6-hour paper, 2 or 3 hour papers, and we had a compulsory question, didn't we? And my compulsory question on my personal little paper was physiology of maturation. Now, anyway, here we go. I still qualified. But I was quite upset about that one, because I was thinking, how does that make me a midwife? But anyway, but we did it. But so everybody knew about the physiology of maturation because it was a compulsory question. But you was actually assessed across the board on the same things. So everybody who qualified at that point had undertaken the same program and undertaken the same assessment. So there was no variation.
And I think it is difficult within university settings because of, and I think you pointed that really out well out, Nikki, because they all have slightly different regulations about length of essays even.
Yeah.
And there's lots of things that have to be complicated. I mean, I suppose in a way the clinical, because there is the MORA, which is trying to
England, Northern Ireland.
But even that's quite difficult. And I know that educationalists and teachers try really hard to make sure that the students are prepared and the midwives are prepared. And I think what you can do would recommend, if you're having difficulty with the midwife kind of understanding what you need to learn or what you need to be assessed on, is contact your link teacher, because they will be able to help, and then that midwife will be helped to understand better. But I mean, it's a huge story, but thank you.
It is, and one thing I want to say about that is, because of the issues in universities, and the fact there is no now process regarding who becomes a midwife teacher, that we are getting more and more inexperienced midwives becoming a midwife teacher. Now, by that very virtue of being inexperienced, as opposed to much older, experienced people who have a lot more to draw on, they are marking students' work, and they might not have come across some of the things. So therefore, obviously you would go to the books and you'd look at the literature, and but there is a risk that things could be marked inappropriately or missed. I'm using worst case scenario, and I would like to say that there are safeguards in universities, such as external examination. Every university has an external examiner, and every university has assessment regulations and boards. But that is there. It has to be looked at. The quality of those teaching and the quality of those marking.
That's grand. Thank you, Nikki. I've got some comments now. We're coming to the end of the questions now, because we're coming to the end of the hour. So I've got a comment from Kemi Johnson. Hi, Kemi, who says, very well said. We've surrendered our role. Not completely, Kemi. I'll take issue with you that. We stepped aside to obstetrics, and the dyads suffer. That's mum and baby. And so do we. We need to create something new. Meanwhile, we as parents are going to prepare from before conception to minimise our dependence on medicalised maternity systems with the support of reskilled real midwives. That's a good thought, because we can still pull it back, because we've had bad times in the past as midwives.
Yeah.
And we've got it back, and we've got it back with women and families. That's how we've got it back. Sometimes we've been quite a bit too laid back in the past. I've been around a while, so I know this. And then we have another comment from Nurapama Prabhakar. I hope I pronounced that correctly, Nurapama. And she says, some women from countries such as India, the country I'm from, hi there, are misled during pregnancy. The caesarean rate in India is alarmingly high. This is also because the private players are market leaders, and caesarean sections are billable, unlike normal delivery. And sadly, in the past 2 decades, women have been brainwashed into thinking that caesarean is normal and the safe process of birthing. And this largely affects women who migrate from India to the UK, as I've seen many women prefer caesarean sections rather than normal birth. Well, that's really helpful to think about. Actually. Thank you, Nurapama. Thank you for that. Now I'm just going through other comments, and we've got Danielle, we've had Danielle and Rachel, and this is a comment. Maybe there needs to be something put in place to discuss the risks in more detail to women who are requesting caesarean section and don't have a medical need. I would hope that would be happening to a certain extent, maybe not. But Ashley says, I agree. I think there's a lot of scaremongering with inductions before 42 weeks, as women are being told your risk for stillbirth is increased, but are not told it only increases by 1%. And then finally, this is Danielle. This is number 3, Danielle. You've been very active. Well done. She says, thank you to both. This has been my first seminar. I'm looking forward to more in the future. Certainly has been an eye-opener, just what I've heard tonight. Thank you. And thank you, Danielle. And thank you so much to our wonderful audience. See, authors of comments and questions. And thank you to Nikki. This is fabulous. This has been a really, and I always say this is the fastest hour in the week, because it just flies by, and I could listen to Nikki for a lot longer, and I could actually listen to some of the comments coming through from the audience. So thank you for participating. We'll have Nikki back, I think. We'll get her into looking at a bit of postnatal care, maybe, because I think that could be quite interesting for us. So I want to say a big thank you to Nikki, and also to Angelo. Now, Angelo is the producer at the back, making sure everything's nicely kept for us and recorded. So it's perfect for us all to access after this. And also Paul, who's been at the back in the background sending the questions and comments through to us, which has been fantastic. Thank you to you, Paul. Remember this, you'll be sent these links again. So if you found it useful, and it sounds like Danielle especially, well done, found it very useful, and I hope you come back again. Do share it, and we're very happy for you to share. This is all free. Just share with your colleagues, and maybe share it and then have a discussion. Think, how could I change it? Now, we did in a couple of weeks ago talk about little changes we can make, little things that we can do, feedback, things we can do about, and in this context, it would be maybe when a woman says, oh, I want a section, just ask her, what makes you want that form of birth. You don't have to frighten women, just give them the chance to talk and listen. Women are always saying, nobody heard me, nobody listened to me, and we need to take account of that. So on that note of listening, and I've listened to your lovely questions, and lovely Nikki, thank you so much for joining us. We'll be here same time next week, same place, and I look forward to seeing many of you back, and Danielle as well, and Ashley and Rachel.
Thank you very much.
Take care. Bye.